All right, good morning. Good afternoon, everyone. I think we'll get started. This is a special town hall meeting that we wanted to put together in order to reach out to our community here of staff, employees of Children's National, to have a mutual update about concerns, but also to be informed by our experts here at Children's National about the current status of coronavirus. I am David Wessel, Chief Medical Officer, here on the podium with Kathy Gorman, our Chief Operating Officer. We've been meeting on a regular basis throughout the last several days and weeks, really, to deal with some of the policy and procedures and plans and to stay in tune with our local agencies and as well as the federal agencies involved in setting guidelines for travel and work and procedures and policies to deal with the emerging coronavirus issue. So the program is going to work like this morning. Kathy's going to have a few remarks to set the stage for our guiding principles. And then we have our two experts, Dr. Song and Dr. DiBiase, who are here to give us more detail about coronavirus. That will be about a 30-minute presentation, and then we'll have 15 minutes to preserve for question and answers that you may have, recognizing that this changes on a daily basis with daily updates and that the guidelines that we put in place today may need modification in 2 or 3 or 4 days from now. So with that, I'll hand it over to Kathy Gorman, who will tell us a little bit about what our guiding principles have been and some of the structure we've got in place to deal with the questions surrounding this issue.
Great. Thank you so much, Dr. Wessel, and thanks for all of you for being here today for this very important town hall. This is not our first rodeo, so to speak, right? We have been down this road before with other emerging special illnesses. And in particular, most notably in 2014 when we had the Ebola crisis that struck. And so many of you have been through that. We have a very, very strong foundation, very strong planning that has been underway for many years. But certainly over the last couple of months, and most notably weeks, and even up to last week, the whole challenge around the coronavirus has emerged into a new level of concern, certainly at the global level. We have had a planning committee that's been in place with senior leadership since almost the 1st of January, where we have been keeping our finger on the pulse, making sure that we're monitoring and evaluating what is happening around the globe. Certainly last week with the index case in the United States, it has heightened everybody's awareness. So we have a lot of planning that's gone on. We have a lot of preparations. We have a lot of facility changes that have even happened over the last couple of weeks. And I really am confident that our teams are ready. But we are bringing this to the next level, and over the next week or two, you'll also see more intense activity around asking for workforce plans, asking around what you're specifically doing for your unit, et cetera. Under that auspices and in conversation and with the vision of our CEO, Dr. Newman, and I know he's probably coming.
He's here in his white coat and he just washed his hands.
Dr. Newman is not in the front row, in the second row. We've got a seat for you if you want. He's next to an ID specialist in his white coat too, but Dr. Newman's ready to go to the OR if he needs to, right? But really, in all seriousness, and coming back to what is at the core of what we are here to, and that is keeping our clinical care, our patients, and our staff safe. And in this order, making sure our staff are safe. We have to deliver the care to our patients and families. We have to be well. We have to keep each other safe. Number two, keeping our patients safe. That is a mantra that we have all the time, but ensuring that our patients are safe and free from infection. And number three, ensuring that we are here for our community. So evaluating what are our surge plans. We've lived through that already with this intensive flu season, but what are our surge plans for the next level of surge? And how do we manage to make sure that we're here for every child in our community that needs us? So without further ado, we're going to turn it over to our experts, Dr. Roberta DiBiase and Dr. Shoyan Song, and we are so fortunate to have both of them here on faculty helping to guide the way.
So there are some seats in the middle and seats down front. If I know it's a standing room only crowd, so please come down, take a minute here. You've heard our priorities. It's our patients, our staff, our community. Now you're going to hear facts, and then we'll come to questions and concerns that folks in the room and folks online. Please stay close to the microphone if you have questions, because we have many people who have dialed in and are on the WebEx Zoom feature for this meeting as well. So, Roberta?
Great. Thanks so much for that introduction. As has been said, we're very prepared. We have worked together for many years on these issues, so we want everyone to feel secure that this, even though it's the first time we're talking to you formally, we've been working on this behind the scenes for a very long time. So that's the main takeaway, is that we all want to stay calm and we know what we're doing, okay? So as you know, this is just the latest of many emerging infectious diseases, and the World Health Organization, the Centers for Disease Control, and other agencies keep very close tabs on this, and we have our pulse on this information as time goes by. So coronavirus, just to get everyone on the same page, is a single-stranded RNA virus. There are different types, alpha, beta, delta, gamma, and bats are an important reservoir for these viruses, with intermediate hosts usually involved in their transmission to humans, but we don't know if that's the case yet for this current virus. But in the case of MERS or SARS, there was a camel or civet as an intermediary host. Human coronaviruses are those that can be transmitted to humans, and there are actually 7 types of known human coronaviruses. The 4 most common types are the ones that we actually pick up on our usual respiratory panels. These circulate globally, especially in the fall and winter. They're responsible for up to 1/3 of any, and on any given time, circulating upper respiratory standard colds. And these are the names of those. So one thing that has come up that people ask us is, does our respiratory panel pick up the novel virus? And the answer is no. It's designed to pick up these usual common types of coronaviruses. In the past, we've had 2 known highly pathogenic human coronaviruses. So in 2002 and 2003, we had SARS coronavirus, and in 2012, we had MERS coronavirus, and now we have a new highly pathogenic human coronavirus. So this is SARS-CoV-2, and this is what we're calling, what was previously called the novel coronavirus. Okay, so the new terminology is SARS-CoV-2. Okay. So one thing that you all have access to, and we do too, is every single day the World Health Organization puts forth a situation report, and we're up to number 41, which came out yesterday, and there'll be another one this afternoon. And it really kind of summarizes what is going on globally. So as of yesterday, there were almost 88,000 cases confirmed. 92% of these are in China. 58 countries were affected. The case fatality rate in China was 3.6%, and outside of China was 1.4%. And every day you'll see the same format, so it's very easy for you to follow this along. I don't have time today, but if you click on this link, it also lists every single country. So there's now more than 70, and it'll tell you exact numbers, how many are new, and if there's local transmission or if it's just a single isolated imported case, okay? And then this is an example of the information you'll see on that report. So this is just a worldwide map showing you by size of dot how many cases are there. And of course, China has a very large dot since that was the epicenter. This shows you the distribution throughout mainland China. And the current biggest hotspots, I'm sure you've been hearing in the news and from Sanjay Gupta, are Italy, Iran, and China, of course, where some of the transmission has tailed off. But as you know, we now have cases, circulating in the U.S. as well, and we'll get to that. Starting around the end of December, so December 30th or 31st, is when the cases were started to be appreciated in China, and there was a whole epidemic curve and peak in China, which has come down. We don't know if there'll be a second peak. That's being followed very closely. But what is clear now is that there are confirmed cases outside of China, and this shows you by date of onset, by date of report, when these cases have arisen. So it shows you that it's on the upswing, which I'm sure you're all aware of now by watching the news. And then by color code, it just makes the point that initially it was really only isolated to the Western Pacific in the middle of February, but just 2 weeks later now we have plenty of cases in Africa, the Americas, the Eastern Mediterranean, Europe, etc. So it really is affecting the whole world at this point, other than Antarctica. That's the last place that hasn't been affected. So this was just updated an hour ago. This is the cases in the United States. So there are actually 10 states that have had cases now. It was just the West Coast, but now we have the East Coast as well. And then locally, we've had 5 cases tested in DC. All were negative. We've had 5 tested that were negative in Maryland, and 3 are still pending. And there were 8 tested in Virginia that were negative. This will change. And we expect that, particularly as the testing becomes more available and the criteria for testing has been broadened. But we just wanted you to know that right now, as of today, there are no specific cases here in Maryland, Virginia, or DC. And again, this is just an idea of what you can find on the CDC website. So this is just today's data. There have been 43 confirmed cases, of which 17 were hospitalized, 2 deaths, and as I mentioned, the 10 states that are reporting cases. And then this just gives you an idea of how those U.S. cases have been acquired. So 17 are travel-related, 26 are person-to-person spread, and then the total of 43. So you should know that there is evolving guidelines for us to determine a person under investigation, and this was most recently updated on February 27th. And the principle here is essentially you need more symptoms with the less amount of exposure you've had, okay? So if you have fever or signs or symptoms of lower respiratory illness, but you are actually in mainland China, or you are specifically with a confirmed case, you're going to meet the criteria. Whereas if you have very severe disease, even if you don't have a known exposure identified, we're still going to consider that as a person under investigation now. So you don't need to perseverate too much over this. I just want you to know that the criteria for who is a person under investigation will evolve, and this is the latest iteration of that. So there are 2 papers that we wanted to make you aware of. There are many papers, but these 2 I think are the most helpful to sort of put everything together that we know so far. This was published on February 24th in JAMA. And it was originally a Chinese Center for Disease Control data paper that was then translated and then interpreted into the JAMA journal so that American and English reading audiences could see the data. And this was the first 72,000 cases, of which almost 45,000 were lab confirmed. The take home here is that children under 10 years of age were only 1%, and even adolescents 10 to 19 were only another 1%. So granted, we don't know if this represents all the infected people, but of the people that have actually been recognized as infected, it seems to be that children seem to be less affected, whether that's less infected or less affected. We don't know that yet. And then you'll see that the 30 to 79-year-old age group is the highest group. So this is from a large data set from China, and we'll have expanding data sets as we now have data from other countries. The severity distribution, mild to moderate disease is the vast majority, so 81% of cases, but 14% were severely ill and 5% were critically ill. And the case fatality rate from this initial series was 2.3%, but much higher in an older population, so almost 15% in those over 80 years of age, and in critically ill patients, almost 50%. No deaths were reported in children in the Chinese data. So that's a really helpful paper. This paper just actually came out on Friday, and this is clinical characteristics of coronavirus disease in China. So this is now more of a medical paper. This is 1,100 patients with laboratory-confirmed coronavirus, and this was across 552 hospitals and multiple provinces in China. The primary endpoint was admission to the ICU, mechanical ventilation, or death. And the results here, there's much more information in the paper if you want to go to it, but these are the key takeaways. Again, children 0 to 14 years of age, only 0.9% overall. Severe cases were older, so 40 to 65 median age versus non-severe cases, 35 to 58 years of age. There is a predominance of males, and that's not understood well yet, although more males smoke in China, so that may be related. And then 6.1% of this group met the primary endpoint. So 5% required ICU admission, 2.3% required mechanical ventilation, and 1.4% experienced death. They only identified wildlife exposure in less than 2% of folks, but the majority did have contact, either being in the region of the epicenter or someone who was in that region. And the incubation period median was 4 days with an interquartile range of 2 to 7 days. Fever was often present on admission and almost always developed during the hospitalization. Cough is very common. Diarrhea is very uncommon, which is one distinction from influenza. And on radiography, ground glass opacities are the most common radiologic finding. But even in severe cases, there can be no findings, although most of the time there is. This is just a picture to give you an idea, because I know many of you are clinicians in the audience, and this is just comparing a non-severe patient across the top with a severe patient, but they both can have infiltrates. Then you can see the ground glass opacities, multifocal nature of it. Some of these patients go on to ARDS. So, this is the #1 question that Dr. Song and I get emailed about. My parents, everyone is emailing me like, well, how worried should I really be, And we always say our job is not to panic, but we do have information, right? So Dr. Song actually found this from the New York Times just yesterday, and I think it's a great picture. So whenever we have these respiratory viruses, particularly newly emerging ones, there's many factors that go into how severe it's going to be and how much it's going to affect our population. So on this one is the fatality rate on a log scale, and on this side is how good it is at spreading, how quickly can it spread. Because you can imagine if a virus is very good at killing its victim, it doesn't really matter how fast it spreads because it's not going to be able to spread. On the other hand, if a virus is very good at spreading very quickly but only makes people a little sick, you may actually have more people affected overall. So this just puts the new coronavirus sort of in context of some of these other respiratory viruses. So here's seasonal flu. It's not, it is not very quick at spreading compared to some of these other ones, but, and it has a low fatality rate, but you have a large number of people, so you end up with 30,000 deaths a year from seasonal flu. Spanish flu, if you remember, 1918 killed millions of people, and part of that was because it spread faster and it had a higher case fatality rate. And so the new coronavirus, it's probably a little less than Spanish flu, but it does seem to spread twice as fast as the seasonal flu, if that answers your question. On the other hand, it's not like MERS, where 50% of people who get the virus die. And it's not like SARS, where 10% of the people get the virus die, at least from what we know now. Okay, so lower case fatality rate than these scarier outbreaks than we've recently had, but moves faster and a little bit higher case fatality rate than we've had for seasonal flu. And this is just another great graphic that she found. If 5 people with seasonal flu infected 1.3 people, we'd have 45 people sick after 5 cycles of disease. In comparison, this novel coronavirus is about twice as fast at spreading, so there would be more people affected after 5 cycles of infection, and that explains why it's been progressing pretty quickly over the last couple of weeks. So at this point, I'm going to transition over to Dr. Song, who's going to tell you specifically about what we're doing here and what you can do to keep yourself and everyone else safe.
Thank you. I need everybody to keep everybody safe. All right, I start with really our preparation started every day. I think whether you realize it or know it or being yelled at or being called out by infection control, that just every day we don't know what we come around, we don't know what we're facing. Therefore, the standard precautions really kind of embedded in our daily practice. And you got to remember to wash your hands, to tie your PPE guns, etc. However, when there is unique virus, there is emerging viruses or emerging infectious agents that come on the surface, we do institute additional precautions as we did in the past. Everybody remember Ebola time, so we have a special precautions. And some of you may remember this H1N1 time back in 2009, and we also went through this whole exercise on what to do and what we should be planning. So we're doing the similar exercise as we're doing with coronavirus. But, and also I want to remind you, as a part of a daily, everyday business, we do keep our situation awareness really on our forefront radar every single day. So as me just like tracking, we track this respiratory viral infections on the every year started from October and around May or June, depending how the season goes. We actually track down how many of respiratory viruses being detected at Children's National, what that means to the patients, meaning like how many got hospitalized and how many actually end up like being admitted to the ICU. So all those numbers historically for the last 10 years is actually available on our internet under infection control page. So if any one of you really, felt like why we were so busy in the last couple months, actually really started from mid-October, even up to this point, because we went through an influenza B outbreak in the community. So no one didn't realize until it's finished then, and we look back at this chart, gosh, suddenly we have this flu B curve all still alone by itself and lasts for 3 or 4 months. Now we are really into this seasonal flu season, and we're still kind of halfway down. We still have a couple more weeks to go. So this is our situational awareness that will keep us knowing what is this unusual high or this is a normal high, so we know what to look for and we know what to prepare for. With this being said, I really, I think we all have been following what just Kathy described in the beginning. The guiding principles for preparing for the coronavirus as a new novel agent. So our first priority is really to keep our staff safe, because we want to make sure we have a healthy you to take our care of our patients safely. So that's our guiding principle, but also we want to make sure we are preparing and responding for a potential surge of patients in the community, which is where we are right now. It's sort of like facing our potential, but otherwise we also have to look into like a possibility of a staffing downsize. It means that we're losing staff because staff could be sick as well. So that's where our guiding principle. And just like you have heard, so this is actually, we're working behind the scene actually just right around the New Year's Eve. It's a very interesting way to enter into 2020. So we heard this news actually start bubbling in China, so they're 1 day, 12 hours ahead of us. So we already, oh gosh, this could be really interesting. Unbeknownst to us, by mid-January, and CDC issued the first guideline regarding what to prepare and what to wear and all those guidelines, because we cannot make up anything until CDC come out with the formal recommendations. So as soon as the CDC issued the first set of guidelines, a couple of days later, we actually issue our own patient screening protocol just to make sure we can capture our patients or potential patients as quick as possible. And also, we did our initial PPE inventory about a month and a half ago, and before I guess most of the people in the country realized what is going on, but we already did our initial inventory check. And we started our weekly meeting back way before this today, of course. And also on January 25th, so we'll actually identify alternative respiratory protection system, and knowing this is as a respiratory viral infection, and it's going to go on to airborne precautions, so we may have to facing some shortages as far as the N95 mask or even pepper goes. And that's, I think, we put out our best on that. Unfortunately, it does come to true. On February 14th, so we actually get a call from a supplier and saying the N95 mask is totally back ordered. We're not really expecting any shipment, but I think at that point we feel pretty good. It's like since we have this alternate system and identified, we actually went ahead and ordered some additional supplies in the meantime. And last but not least, we're actually able to just validate our functionality of a 5E special isolation unit. For those of you who have been here for maybe longer than 10 years, you probably all have seen that 5E works, but here's what it's designed for. This design actually came into us like in 2007 when the building delivered to us, there's a whole floor delivered to. You probably don't notice it. We probably won't see that function, but at this moment, this is exactly what we need. So patients can be taking, this is what we call the special isolation unit. patients can be taken from back door outside of the building and then go through this kind of triage room where when we actually need this whole triage room in the airborne isolation mode, or someone just call it as negative pressure mode, we can turn on this machine and this entire section will become airborne precaution mode, which is negative pressure with a direct exhaust to the exhausting system of the roof. And so we'll take the patient in from the back door and go through the screening. We started from field zone 1, which is the back section of the 5 East. If we started getting more patients in, we're going to gradually move into zone 2, and then eventually we'll take over entire 5th floor, which is zone 3. And with all 3 zones that can come in place, we're gaining additional 60 beds that's fully equipped with the airborne precaution function. And in addition to that, we do have additional 46 beds throughout the entire hospital, and that's where we are still able to take care of the patient who actually on TB, chickenpox that require the airborne precaution as well. So this is really a nice feature we think ahead. Thankfully we're able to think ahead like many years ago. Now it's really needed. And besides, we have this PPE and the facility readiness. We also kind of plan ahead as far as the staff safety, because the one way is to get person exposed during the work, but also, of course, we're part of a big society. When you travel, when you come to, social with anyone around you, that could be also accidental exposure to the infectious disease as well. So that has been this committee we're watching at. First started with the global travel policy. That's actually initiated on January 28th and started moving on, because to make this travel policy successful, we need HR policy to come along with it. So thanks to the HR colleagues, they've been working with us around the same time, and so is the occupational health. They're doing great work behind the scene and make sure the staff can come back work and safe. And last but not least, last week we did expand the travel restriction to all countries right now with the level 2 and 3 alert, which affect 5 countries at this point. But as you heard from Dr. DiBiase, this list could continually change, either going up or coming down. So before any one of you travel or plan to travel, check that website first. This is the website, and we're not going to show you how to get to it, but if you log on to cdc.gov, and it will be banned, that coronavirus is right onto your face. It's there. So click it, and then there's a travel section, and they will give you all the details on, where and if they think that's a concern. And then last but not least, as we said, now we do have to plan, any of the emerging infectious disease. So there's the plan for the community outbreak is always in the back of our mind, and so is for the coronavirus. However, I have to say, this type of interaction, there's no difference than any other, things that could happen to an institution where it suddenly interrupts our normal business continuity. So we're not reinventing the wheel, so we're going to use the exact same framework a great team had worked on for months or if not a year, and develop this beautiful framework. And we're going to work off the same framework, but we're going to have some plans tailored around the coronavirus, and that's going to complete by end of this week. So, like I said, we keep on saying we're ready, but indeed, we're not ready until you are ready. So I'm here really also look at all of you and all the entire institution, say, you have to help us, we help you, and as a family, as a large community, we're here together, we're in this war together. So we have to fight for it, and we have to win it. So with that being said, and I cannot emphasize enough at this moment, and especially with the spring break as coming up, and lots of travel are actually already planned or in the plan. So before you go, first thing first, check out to the CDC web, because lots of people do want to go to some place warm and nice, and so this international travel is clearly identified by CDC at this point. So if you do decide to go, at least let your manager know and where you're heading to, and what could the potential, if you have any doubt in mind, let your manager know, and manager should just escalate that question or concern to our attention. We actually have a steering committee right now to justify every single case on a case-by-case basis, and the HR colleagues also weigh in terms of what's the implication as far as our occupational health implications associated with the travel. And also, I think I just still want to go back to even before you travel. If you don't travel, you work through the whole spring break, but every day before you come to work, we always say if you are sick, stay at home. We knew it has now been possible to do this every single time. But now I think I just have to remind you one more time, it's like if you don't feel well, at least call your manager and, sure they can make sure everybody on the same page. And last but not least is like if you start hearing like someone you actually just spend the whole weekend in their house, somehow come down with suspect, I want to confirm that could happen. And if that happens, and also let us know so we can be on the same page.
Jan, can you just mention are you going to mention the travel reporting?
Let me just finish and we can do the QA. Thank you. So what else? Once you come to work, standard precaution first and apply to every single time, every patient, anytime you touch a patient. But also, we do have a COVID hub, and now it's set up. It's hosted by the infection control webpage. So come to check on this hub often because our information do get updated as new information become available to us. I want to go through, this is our isolation, it's all called a screening tool, and actually also it's not only available in paper form, but in Cerner. So if you are checking on the patients or do an intake and suddenly alert pop up, don't think, oh, that just kind of false. No, it's real. So we have a great Cerner team who are able to actually get this into Cerner in 48 hours. So it's just amazing teamwork behind the thing. So if you do have this pop-up when you do the intake, follow the procedure. So that means you're going to, first it's like, we're going to say like, this is for early identifying a patient. So once the patient is identified, you put this patient on isolation first. And then you're going to, every single time you go in to actually take care of this patient, we actually have a full PPE protocol spelled out within this tool. Last but not least, you got to notify infectious disease attending on call right away so we can assess and proceed for the next step. This is the PPE required. We, as acute care hospital, this is the highest standard that will be required to adhere to, and this might be different for community providers. So I will going to address this later, but just so you know, this is the required PPE for taking care of patients either suspected or confirmed coronavirus patient. And so it does require both the contact. If you use an airborne, but airborne, we have two ways to do the airborne. One is N95 plus the face shield or using pepper. So this is actually the standard for the time being. And what about if we have a patient, now it's being identified, and now we'll put the patient in the isolation room just to make sure everyone on the same page. We actually have the special precaution signs created available on our internet. So while you're doing everything else, do not forget to just print out the sign and post on the patient door. So to prevent other people accidentally walk into the room without knowing the condition or status of the patient. So this isolation sign is a part of infection control protocol. It does spell out what to wear and what to use when you have to clean the room and how to handle the equipment, as well as how to transfer patients safely. There has been lots useful resources available from the local, regional, national, international settings. So this is just a few, and if you don't bookmark anything else, those a couple of sites do bookmark on your computer, because those information, if you keep on checking back between 5 sites, almost every 10 minutes you need to refresh it to get more updated information. I do wanted to point out, like I mentioned before, providers in community practice must consult your local and equal to to the county Department of Health first, because Virginia County and Maryland County might have county level, not even like a state level, county level might have a totally different protocol for the local practice, and absolutely has a different numbers for the local practice to call. So I urge you and get on, and after this, the whole grind round, really make a call to the county Department of Health first to find out whom should I call, what number should I call in, and when do you want to call in for what. So every department health will really be our first go-to partner. And I'm also working with state department health and hopefully to set up some webinars which will gear towards the community providers at this point. And once the information, that webinar information become available, I will let everybody know as well. This is a steering committee has been working behind the scene, and I just wanted to show the size, and I think everybody will appreciate it when everything's over, we can have a party. But for now, the Corona is going to save where it needs to be. Thank you.
So that really concludes what we're going to give you for information, because we really did want to leave a lot of time for questions. I mean, there are many, many topics we could talk about, but the purpose of this town hall was to make sure we're getting you general information, that you're aware of what we're doing here at the hospital. But we're happy to field any questions that you have, all of us. Yeah.
Is there someone with a microphone? Yeah, we're going to try. We have a lot of people at our very important clinics that are part of our organization, and we want to make sure that you ask a question, you speak into the microphone so they can hear you.
Just a quick one. Do we know anything about how long this virus may survive on surfaces, and do you have any recommendations as to, especially where we have shared executive office spaces, should we be cleaning those phones, or what do you recommend on that?
I'll make a comment on this. I don't think there's a definitive answer on how long exactly, but there does have evidence showing it can survive on the environment. So as always, I think you clean and just at home using Lysol, that type of disinfectant, and in the hospital, our disinfectant wipes that the hospital uses does kill the coronavirus very well. So use a few, a handful, at least do once a day, if not more often.
I mean, and that's just good practice, whether we have the flu going around or RSV or whatever. Let's wipe down our surface.
And your cell phones. That's probably the number one fomite, as we would call it in infection control lingo.
Yes, could you please clarify the situation with the masks? Do the regular surgical masks do anything? And if not, you said that the N95s are restricted, so what exactly does it mean when we are on the floor to see patients, and what do we do in the clinic?
So at Children's Hospital, you will wear an N95 with a face shield or a PAPR system when we see patients, and we will facilitate that for you. And the reason why we're restricting N95s more than we usually do in the hospitals, we need to preserve those for this situation right now. If you're out in the community and there's no N95s available, because this virus is primarily droplet transmission, not airborne, it's probably fine to use a standard mask if you have nothing else. But in a hospital setting, we're going to be at a higher level, a higher standard, and use either the N95 with a face shield or the PAPR. Does that answer your question?
Yeah.
Now, if you are an actual patient or you're coughing and you have COVID, then we'll put a standard mask on you because that prevents it from coming out. But for the actual healthcare provider, you're going to wear an N95 with a shield or a PAPR. Yeah.
But I also want to comment on this. If you do have a patient suspected, with the coronavirus, and whenever we transfer the patient outside of a negative pressure room or airborne precaution room, put a mask on the patient as well. That's actually
a regular mask.
The regular procedure mask, or surgical mask, just because that's the best way to capture the virus within the area.
Andrew.
I just got an email just now, actually, from the special category programs. I have an international observer who is supposed to be coming in a few months from a non-currently affected country, and the email states that currently the program is shut down temporarily for all visitors, which I understand. I just thought maybe you wanted to comment on that and talk about what the plans are and timing and how that will affect international visitors.
All right, let me try to review that briefly. It's complicated for different categories of individuals. But first and foremost, let me talk about Children's National employees who are going abroad or have been abroad. Right now, you saw the CDC list of 5 level 2 or level 3 countries where we as an organization, as an employer, have said, do not go there on business for Children's National. And we expect that for the safety of our staff and our patients to be adhered to. What then happens is that if someone is in a country now working for Children's National, on business there, and that country emerges while they're there as a level 2 or level 3, then when they come back, it's going to be necessary to quarantine them for 14 days before they return to this hospital. And that needs to be closely coordinated through the managers and through occupational health through a telephone conversation, not appearing on site at the hospital and wandering over to occupational health. We recognize that there are other places where people may plan to be going very soon, and there's a lot of emails about that. We want you to use good judgment. If it's very elective, you know you're going to be going through international airports where people from all different countries are traveling. It may make a lot of sense to be prudent and to defer your travel. That's not necessarily a mandate, but we really want you to be using the best judgment that you can. For those folks that are going to a country, like today, for example, at 4 o'clock, there are people leaving to a country that's not on the list. And, you know, California is not on the list, or Washington. If we think there's a really important leadership role that Children's National has to execute this meeting successfully in that country, and there's no reason to think that tomorrow it's going to blossom into a country where there's a lot of disease, then we think it may be reasonable for the group to go ahead and go to that country. But here, that's where you start to get into a lot of, you know, decision-making where managers and leadership of the hospital need to try to make good, consistent judgments. Now, you're asking about observerships and other programs where we think international observerships really, I think we've put, and I want to connect with occupational health, we have put them, Michelle, on hold. We think there's just too much risk. They're not our employees, they're not our patients, they're not our staff. Now, we've had some international patients who are scheduled to come. I know there's one from one of the 5 countries, and we've been able to defer that transfer to for an elective procedure at Children's National. So some of these require individual judgment, and I've talked too long, but if we need to continue the conversation.
One of the important things that Dr. Wessel mentioned as well is this is changing every day. So our leadership team meets very frequently, daily, if not every other day, to evaluate where we are. And so this will change. This will change. And as we need to become much more conservative, we'll be sharing that information with you as well.
Dr. Arroyo from Pulmonary, any timeline into when are we going to have available the testing for the virus?
So, you know, right now the CDC is the only place that does testing in the U.S. I had a slide that shows you there's like, 12 places in the whole world that are qualified right now to do it. But the plan is to expand this. So the first expansion, though, is going to be to the health departments. And then the FDA, there's actually someone talking about it today that bumped me off a C-SPAN, darn it. They're talking about getting emergency use authorizations for various companies that are, building kits that can then be validated and then pushed out to hospitals, et cetera. But the first step will be pushing it out to the health departments. And then the criteria for testing has already expanded because, they've expanded. It's clear that you can't just say, have you traveled? Because now we have cases in the U.S. where there was no travel exposure. So the CDC will allow more people to be tested.
Dr. Ogunlesi from Pulmonary. I just want to go back to Andrew's point and Dr. Wessel, your what you talked about travel. I just returned from Nigeria on Thursday, but Friday morning I walked straight to occupational health to get my temperature taken. I have a student who is here from Vienna, who also just came in yesterday and is in our division for an elective rotation for the next 4 weeks. When I walked through the airport, and he said the same thing, the only question that was asked was, have you been to China? the first case in Nigeria was reported on the day before I left Nigeria. And actually in a vicinity not too far from in Lagos, which, and I'm sure you can imagine that the surveillance and stuff is not that, as robust as it is here. This was an Italian who came in for a business trip to Lagos and was leaving that same day and was found to be positive because he was ill. I'm bringing this up just because I'm not sure what the surveillance is for here, and there are lots of people coming in and out of DC from different parts of the world, or maybe have even been here. So I don't know if you can comment on that.
So I appreciate your vigilance with reporting into occupational health, even though Nigeria is not on the level 2 or level 3 countries and has very few cases reported. So I think it's a good example of checking in for the right behavior. It also points out that we may need to be more restrictive and anticipatory in our actions because we serve vulnerable children. And we serve a healthcare community here that's important for the well-being of our children. And so we may need to be more restrictive because of the recognition that people are passing through international forums where there may be exposure to this virus. So I just want the community here to understand that if we seem to be a little bit more restrictive about saying, all right, we're going to stop all visitors who are coming to do rotations through our institution who are international, and we're going to put those off for a while. That's more restrictive than you might think, but we're in a special position here of caring for these children, and we need to be more compulsive about our behavior. So I think if you just look daily at what we're announcing and trying to decide with the input from our experts and our chiefs that we've been constantly in contact with, it'll provide guidance for what employees and others can go abroad or can come back without quarantine.
And also, just want to add to it, since the situation really changed very rapidly last week very much last week. So on Friday, as soon as we made a decision going to temporarily suspend this international special category visitors to all observers. I do have a list of people who, and also a list of people who plan to come. So we made sure at least enough of them directly come from the country we're currently on the list. So we're going through the list and are going to go through into the details on what we're going to do for the people that's already here and versus also for the one that's headed.
And Michelle McGuire is in charge of that international effort now and is in close contact every day with us, trying to make sure that we send the same and consistent message updated each day.
Leah, you had a question? Can you,
Yeah. So there is work on vaccines. The NIH is working on a vaccine, and it'll probably be in a phase 1 clinical trial by April. There's also clinical trials that the WHO, if you go to their website, there's actually a international clinical trial protocol that everyone will be using the same protocol, and they'll just be plugging in different antiviral treatments. So there's at least 3 that are going to be under clinical trial shortly. So, but none of that's going to help us right now. And a vaccine, that's a year till it's used in the general population. So we really have to focus really on the usual stuff, which you hate hearing us say, but wash your hands, sneeze in your elbow, stay 6 feet away from people, don't go to places you don't need to go, for a while till we figure out what's going on. And then as far as travel, don't try to figure it out yourself. I think that's really the bottom line. We're giving you some resources, but just call us and we'll tell you what to do from day to day.
We'll take 2 more questions. Kathy, and then there's a hand up over here. Kathy.
And so there is a system that leadership has created in terms of surveillance for our staff. There is a travel reporting staff website, which again is required if the institution is footing the bill for your trip, but you can also use it for vacation. And this has been incredibly helpful for us to then track down people when new countries come up as to where people are. And so the website isghireport.childrensnational.org. And previously it was just for faculty, but has been now opened up so that nurses can use it, staff can use it. So that's a way for us to keep track of people. So if something comes up, we can have general knowledge of who is coming back. With that website, what happens is you put in your dates, and pretty much the day or 24 hours before you're slated to return, you get an email so you can self-clear for occupational health. So you don't necessarily have to come to campus and go and report, but you will get an email. You fill out you go back to the portal, you fill out your questionnaire for your health, and if everything checks out, come back to campus, you've self-cleared. But if, you're having symptoms, fever, or, there's a question in terms of which country you've come to, then you call occupational health. And that way, we have a systematic way of keeping track of people who are coming back from vacation. Because as you mentioned...
Let me reiterate the first part of that. If you are going to have international travel coming up, discuss it with your manager, fill out the form, and make sure, whether honestly it's vacation or work, we know where you are because we're invested in you as one of our employees, and we want to help and give good advice. Last question.
What is HR's response to those who need to be quarantined for those who are either on business travel or for vacation?
Right. So there's a graded response, and it may change depending on the needs of the community and the prevalence of the disease in our community. But right now, what we've said, if we see that a country is level 2 and level 3, and we have put out the message that we do not support any business activity and our folks going now to those countries, then we expect people to follow that direction. If they choose not to, or if they even go on vacation to one of those countries, after it's announced that that's on the sort of no-fly list, then when they come back, currently what we've said is that those folks would need to be on their vacation time during the 14-day quarantine period. If they're in a country that becomes a level 2 or level 3, doing business for Children's National, then when they come back, and we have several people now who come back during that time, are on administrative leave. They don't have to take their vacation time. But knowingly violating the direction is, I think, not what we'd expect of our employees. And we also can't put the financial burden of that on the hospital and all the rest of us. So and again, that's something we need to evolve a little bit as we think about what the needs are of people to travel abroad for some critical functions. All right, I know. Last one.
Again, the website.
We'll send it out. We'll send it out,
we'll
Judy.
Put it on the main webpage.
Yep. We'll make sure that that is on the coronavirus site. That I know we've had how many hits already? 9,000 or something like that? Yeah, PR is keeping track of how many hits, so a lot of hits on that. So thank you, everyone, and if you have any further questions, don't hesitate to reach out. Very good.